Thanks very much. So I want to first thank the symposium and also CanEPSI for giving me this opportunity today to present some of my research. I want to also thank Dr. Hagen also to have introduced some strategies that people who inject drugs use for preventing HIV, because it's quite related to what I'll be presenting today. So for most people who inject drugs, temporal injecting patterns follow a dynamic process characterized by transitions in and out of injecting. We have different profiles. Sometimes it's frequent, not frequent. There are some longitudinal studies on injecting behaviors that have shown that 6 to 37% of the participants, depending on the study, were presenting some trajectories characterized by multiple transitions in and out of injecting over a period of 8 to 20 years, again, depending on the study. It could either to stop using drugs for different reasons or change mode of administration of the drug also. And also it has been suggested that transitions out of injecting could reflect a desire to moderate drug use, as suggested also by Dr. Hagen, avoid physical complications such as abscesses or cellulitis, or prevent exposure to associated health risks such as HIV and HCV. Yet the evidence is quite scarce. In a sample of young people who inject drugs in San Francisco in the US, so they have demonstrated that having at least one 3-month injecting cessation episode is associated with a reduced risk of HIV acquisition. However, previous studies, most of the ones I've cited previously, have not examined injecting cessations of shorter durations. Here I mean, I refer to episodes of shorter than 3 months. And this they could happen in situations that are frequently experienced by people who inject drugs, such as short-term incarceration, detoxification, or inpatient rehabilitation, for example. And also in some previous work we've shown that short cessations were associated with a reduced likelihood of receptive injecting equipment sharing compared to continuous injecting. So, of course, you won't be surprised by the hypothesis I'll be presenting you. So the objective of our study was to examine the association between HIV acquisition and short injecting cessation episodes, so cessation episodes that are shorter than 3 months. And the hypothesis was that short injecting cessation episodes will be associated with a reduced risk. So I've been working with data from the Hepatitis cohort study that is based in Montreal. It's an ongoing observational cohort study of active people who inject drugs. So people were enrolled if they injected in the 6 months prior to the enrollment, and people were enrolled through referrals from community-based programs, posters, word of mouth, cards, etc. And it is based in Montreal, and of course people needed to be age 18 years old. Also, the inclusion criteria for this study, people needed to be assessed between March 2011 and December 2014. Of course, not being actively infected with HIV infection. So people could either be antibody positive or negative, and people needed to have at least one follow-up assessment. So people were followed up every 3 months, and at baseline and follow-up visits, they answered an interviewer-administered questionnaire, answering questions about social demographics, drug use-related behaviors, and service utilization and treatment. And people were also tested for HIV antibody and HIV RNA. So the exposure of interest was short injecting cessation episodes. So actually, at each 3-month follow-up visit, people were asked if they injected in each of the past 3 30-day periods. So in the first month, have they injected, yes or no? Second month, yes or no? Third month, yes or no? And then with this data, we created a 3-level categorical variable that was actually cessation in 0 out of 3 months, which was representing persistent injecting, cessation in 1 or 2 out of 3 months, which was representing short cessation episodes, so episodes that are shorter than 3 months. Otherwise, sustained cessation was defined by cessation in 3 out of 3 months. And also to assess drug injecting, we were using timeline follow back method, which ensured some better reliability and validity of what we were measuring. The outcome of interest was HCV acquisition, so people that are either tested HIV RNA positive or antibody positive following a negative test. So people were either at risk of primary HIV infection or HIV recurrence. What I mean by HIV recurrence is HIV either reinfection or relapse, although we believe that most will be reinfection cases. So people, again, were tested every visit, and the new infection was estimated to occur at the midpoint between the last negative, and the first positive test. For the statistical analysis, we did some Cox regression analysis for time-dependent covariates. For the multivariate models, we adjusted for age, gender, and opioid substitution treatment, which was one of the one of the most potential covariate in that study. Also, we did some cumulative incidence curve for time-dependent covariates, which is a special extension that is available in the STATA program. So for the results, 311 participants were eligible for inclusion in this study and contributed 56.7 years of follow-up. So people the mean age was 40, most of them were male, and about half were eligible for HCV reinfection instead of primary infection. So when we're looking at the results for HCV infections, we got about half-half, so 34 primary infections and 29 recurrences, and the HCV incidence was 11.3 per 100 years. When we're looking in that table there, the Cox regression analysis, we can see that at baseline, 25% were categorized as short cessation episodes, so it is something that do exist among this population and needs to be probably assessed. And also when we're looking at unadjusted analyses, we can see that short injecting cessation episodes were associated with a reduced risk of HCV acquisition, and of course, sustained cessation was also associated with a reduced risk. When we divided in two categories, so cessation in 1 month and cessation in 2 months out of 3 months, the hazard ratio was about the same. Although the confidence intervals were quite large, probably for a reason of power, so that's why we kept these two categories together. When we're looking at the adjusted models, so adjusted for age, gender, and OST, we can see a 60% reduction of HCV risks in short cessation episodes and 70% reduction of risk for sustained cessation. When we're looking at the cumulative incidence curves, we can see it gets quite obvious. So we got the top green line that shows persistent injecting, so of course the highest numbers of HCV acquisition. And the bottom one is sustained cessation. And in the middle, we can see the red line that represents short cessation episodes. I guess we could have expected some less cases of HCV infection among the sustained cessation. And I could explain to you later if we have time why we think that some cases were associated with sustained cessation. So short cessation episodes were associated with a reduced risk of HCV infection compared to persistent injecting. And we believe that it's plausible that participants experiencing short cessations were more aware of or concerned about injecting-related harm and more likely to engage in safer injecting behaviors, as we've discussed a bit earlier, and maybe also in the process of achieving sustained injecting cessations, although we didn't really assess what was the timeline, what was the relationship between sustained cessation and short cessations. Also, there are many possible mechanisms, and we believe that probably that short cessation episodes could contribute to improvements in economic, social, or spatial environments that otherwise would compromise the ability to inject in safe conditions. Also, we believe that in the clinical setting, relapses to injecting should not be approached as failures given the demonstrated benefits of short cessation. So instead of focusing on the relapse, let's focus on the episode and all the benefits that the person got from it. Also, we believe that this could contribute to better awareness, and we believe that awareness of and sensitivity to drug injecting variations or profiles could contribute to reduce stigmatization and misunderstanding regarding the needs and lifestyle of people who inject drugs. Also, we believe that it could altogether contribute to an improvement in patient-provider relationship and also in engagement in care. Finally, we believe that short cessations could be some good moments to intervene to promote linkage to harm reduction opportunities, especially in situations where we have a bit of more control, such as incarceration and detoxification. So these are my acknowledgments. I want to thank my supervisors, my scholarships, and also the HEPCO research team and participants, obviously. Thanks very much.
Hi, that was an excellent talk. Thank you so much. I really liked that. So have you thought about, I know that Don Desjardins had a paper from New York City that showed that there was a reduced risk for people who went from injecting to snorting, right? Snorting heroin. And I'm wondering if you thought about like the the intervention potential for these findings in terms of like a behavioral intervention that might encourage people or instruct people how to, resume snorting? What do you think about that?
I guess, so I did talk about interventions that could promote linkage to harm reduction strategies, and I guess some good results we have for OST and needle syringe, particularly where there is reduced drug use, there is also reduced needle syringes. So I guess these strategies are efficient for reducing drug use itself, and probably that some interventions promoting transition to another drug use should be probably integrated in these situations. Yeah, thank you.
Thanks for a really great presentation. I have a question. What types of drugs that people were using? Did you take a look at that? Because certain drugs, such as cocaine, tend to have periods where you might have intermittent use more than someone who's chronically using opioids.
So I guess I had a slide, a backup slide, but so I guess the majority are injecting cocaine. So it's about, I think, around 60 to 70% are injecting cocaine when we're contabilizing all the study, the visits that were included in that study, and a bit less, or around 45%, I guess, were injecting opioids. But so I have only reported the drugs that were injected, though, so not the drugs that were used.
But the risk is often higher with those who are using the higher rates of injections, like methamphetamine or cocaine. So it's kind of interesting.
Yeah, absolutely.
I don't know if you looked at the effect of the drug itself that was used in part of your adjusted analysis. So it might be interesting to look at.
I think you're right, although I think we have some varying results about that in our study itself, but I want to go further, so I don't want to say any. Thanks.
Very nice presentation. Quick question. I'm glad you have this up here, so this helps. Did you look at the time of acquisition in the patients that had these short interruptions in terms of, because you could have 1, 2, or 3 interruptions, right? So first of all, whether people had more than one, whether that was associated with a lower risk, so if they had more than one interruption in their injecting use, but also if someone had an interruption at their the third month of those 3 months, did you count them in your failure probability? Where do they fit into that curve? I'm curious whether people got HCV after returning to injection drug use, or whether they actually acquired it before they had their interruption. Did you correct that analysis for that? Do you understand what I'm asking?
So actually, I think the way Cox regression does it here is that it is associating the risk of HIV during that 3-month period. So if people were, for example, infected during short cessation episodes, then that's what is reported on the graph here. But then I'm not sure to understand your question. I'm sorry.
Well, it's just really about when the occurrence happened in regard, like when they were infected in regards to when they had the cessation. So if they didn't inject in month 1, and then they did inject in month 2 and 3, the Hep C injection presumably happened when they returned to injecting, although I'd like to know that, because you have some occurring in the people with persistent cessation.
Sadly, we didn't look at that. I'm sorry.
Okay. It just might be an interesting thing to look at about whether, because I guess the one thing I'd wonder about is whether when people stop their short cessation, whether they go back to any higher risk injection behaviors, out of their return, because something may have happened in their life that leads them then to return to injection behaviors, which may be higher risk. And so I was just wondering.
So we did a study, as I said before, and we showed that people who are returning to drug injecting are sharing less. So it kind of answers a bit your question. But then the timing is not that convincing, but it is the hypothesis. We had the inverse hypothesis, as you suggested, maybe a more chaotic period of injecting following a cessation, but our results don't really suggest that. Thanks very much.
Thanks.
Okay, thank you very much.